Okay, I think I'll kick us off and people will join as I give my intro. For those who don't know me, my name is Dan Carbon. I'm a principal at Santis Health, and we're really excited about moderating today's webinar, which is being presented in partnership with the Ontario Medical Association. It's clear that there's a huge amount of interest in the topic we're going to be discussing this evening. We have almost 100 folks on the line already, and the RSVP list has several hundred with really broad interest spanning clinical, administrative leadership in the system, academics, health policymakers, and private sector executives. I want to welcome all of you for what I hope will be a timely and engaging conversation about how to reorient our system to significantly improve public access to care. Any of you that work in healthcare or even just read the news know that our health system is facing a monumental challenge in recovering from the pandemic. Over the past 2 years, hundreds of thousands of scheduled surgeries and diagnostic procedures were canceled, and hundreds of thousands more were never even scheduled because people who needed care didn't access the system. What we initially hoped would be a temporary pause in health service delivery became a multi-year interruption in access to care. Even if we could wave a wand and turn the system back to 100% capacity, or even ramp things up to 120%, clearing this backlog would take several years to address. But we know that we can't do that. Even before the pandemic, Ontario and Canada more broadly had profound challenges ensuring timely access to scheduled care. The reason our system ranks second to last in the Commonwealth Fund review of advanced health systems is because people here are forced to wait much longer for treatment than almost anywhere else. Our hospitals have always been asked to run at and often over capacity, and we have amongst the fewest hospital beds per capita in the OECD, which might be very financially efficient in normal times, but offers us very little flexibility to deal with surges, either those that are planned to get through backlogs or those that are unplanned associated with pandemics or infection surges. And we're also now dealing with widespread health human resources shortages that show little sign of abating over the next few years. Hospitals and other service provider organizations, whether they're in home care, long-term care, or the community, are reporting profound staffing shortages and endemic burnout of nurses and other frontline staff. With the system that we actually have today, hoping that we can simply announce a few $1 billion in funding and that things will sort themselves out is optimistic thinking at best and downright dangerous at worst. The existing delivery system will struggle to ramp up capacity enough to deal with the COVID backlog, let alone all of those people who are already waiting for too long from before the pandemic. We really need to consider a new approach that will maximize the productivity of our health workforce to serve as many people as possible with the highest possible quality care, and do that in a way that avoids further straining an already burned out healthcare workforce. This means thinking not just about efficiency, but in innovation and how we move people from assessment to treatment, how we deploy capacity across a region, not just a physician's practice or a hospital, how we use new models of interprofessional care, and how we deliver surgeries and other procedures in settings that are most appropriate for the level of need. Ontario's traditionally been a laggard, not just in the OECD, but even in Canada, in deploying ambulatory models of care to speed up access to surgery. In 2021, a team from Santis Health began working with the OMA to review the current state of access to scheduled care in Ontario and look at how the pandemic was negatively impacting public access to care. The OMA had already identified that addressing the care backlog would need to be a key pillar of the province's health system COVID recovery. Earlier this year, the OMA released a blueprint for the province to systematically tackle the backlog in scheduled surgeries and procedures through first maximizing all available system capacity, and then building and expanding capacity through a network of integrated ambulatory clinics that could provide a broad range of care on an outpatient basis. In today's webinar, we're going to explore some of the ideas presented in this paper and consider other approaches to reorient the system to ensure our capacity to deliver care in the future is more aligned with growing public demand. Before we start, I'd like to briefly introduce the 4 panelists for today's discussions. I'm really excited that we have this group in attendance today. And I want to note that for the purpose of brevity, I'm significantly abridging these bios. There are comprehensive bios in the Zoom link, and they'll be sent out after if you want to learn any more. And I'm sure you could also Google these 5 folks and find out lots more about their background. But to summarize, the first person I'm going to introduce is Dr. Adam Kassam, the current president of the OMA. Dr. Kassam is a practicing rehabilitation doctor working as a clinical associate at Runnymede and Athletes Care in Toronto. He also holds privileges at Sinai Health and St. Joe's Healthcare London. On top of his practice, Dr. Kassam is a lecturer at the University of Toronto Department of Medicine and has served as a board member of the Heart and Stroke Foundation's Young Leaders Committee and is often called on to contribute as a writer and medical expert in national and international media. Also joining us from the Ontario Medical Association is Dr. James Wright. Dr. Wright is a pediatric orthopedic surgeon who spent most of his career at the Hospital for Sick Children in Toronto, where he served as the Chief of Perioperative Services and Surgeon-in-Chief at one of the busiest and most advanced pediatric surgery departments in the country. He is also the president of the Pediatric Specialties Association and chair of the Pediatric Surgical Chiefs of Canada. Since 2018, Dr. Wright has been the chief of the OMA's Economics, Policy and Research Division, where he's leading health system transformation. Outside of Canada, Dr. Wright taught and conducted research at the University of Oxford, which a few of you might have heard of, where he served as senior research fellow and professor of orthopedics. Overall, Dr. Wright has contributed to more than 240 peer-reviewed publications in journals, including The Lancet and the New England Journal of Medicine. Welcome. Our third panelist is John Yip, who is the incoming president and CEO of SE Health. I should know this, John, but I don't know if you've started there yet or if, no, it's pending, it's very soon. John's joining SE after serving as president and CEO at Kensington Health. Kensington is, of course, one of Ontario's leading models of ambulatory surgical delivery, but also offers a range of other community-based residential and ambulatory services. John has over 20 years of healthcare industry experience. Before Kensington, he was the VP of Corporate Services at Health Quality Ontario and a management consultant basically everywhere, it looks like, CGI, KPMG, PwC, before founding his own healthcare consulting firm. John's on the board of the directors at Triathlon Canada, the Centre for Effective Practice, and the Regional Geriatric Program of Toronto, and is a member of the Institute of Corporate Directors. And finally, our fourth panelist, who I'm delighted to see was able to jump out of a meeting and get here on time, is Melissa Farrell. Welcome, Melissa. Melissa is the current president at St. Joseph's Healthcare Hamilton. Sorry, I'm just having some technical difficulties here. And is also a lecturer at McMaster University Department of Medicine. Melissa, I'm having to ad hoc this because my page prior to joining St. Joe's, Melissa had a long and distinguished career at the Ontario Ministry of Health. What's relevant to this group, I think, is back in 2003, Melissa started working as a member of the government's health results team on the wait time strategy. So has a long history of working on access to care issues in Ontario. After working on wait times, Melissa progressed through the ministry, became the director of primary care before becoming the assistant deputy minister responsible for hospitals and emergency management. I hope I got that all right. So welcome, Melissa, and thank you for joining us. I'm just going to go on to a few housekeeping matters before I turn things over to the panel. The first is that, notwithstanding my comments in the introductions with Dr. Wright and Dr. Kassam, they've asked me and the fellow guests and members of the audience to refer to them by their first name. So welcome, Adam. Welcome, Jim. I hope you enjoy the session. Second, I wanted to let everyone know that at the end of the webinar, there'll be a link to a brief survey. If you have time to complete the survey, it would be greatly appreciated. Third, everyone probably saw a note that we're recording today's webinar. If you have to pop out for anything, or you have to get some dinner, or your dog barks, or whatever it is, you can see a link to this webinar tomorrow in your email and catch up on anything you might have missed, or if you want to send it on to someone else. Finally, I want to draw people's attention to the fact that at the bottom of your Zoom, there should be a Q&A function. Our hope today is that we have a really dynamic discussion, that we have a lot of time for questions from the audience, and we're able to pose those to our panel. Please feel free to send in questions at any time. John's smiling, just worried about the questions that he's going to be facing. please feel free to ask any question that comes to mind throughout the conversation. We're going to be triaging those and hope to get to them through the course of the conversation. This is really an opportunity for us to share and learn, and we really hope that there's broad participation. So with that, I'm going to turn things over to Adam and Jim to kick things off. They're going to start with a brief presentation.
Thanks so much, Dan, and good evening, everyone. It's really great to be here, and really thank you to Santis for the invitation. Thank you all for spending a little bit of time during your precious, afternoon, evening with us here on this panel. And I want to start off by obviously telling this group just how important we believe that this conversation is going to be today. Obviously, one of the biggest issues that we're all facing as a health sector are the sort of growing wait times and the backlog of care as a result of the pandemic, but also in the context of a growing wait times. Frankly, it's a crisis that has been growing for decades, if not longer than that. And so we're really here to talk about those two issues, wait times and backlogs of patient services that really are putting Ontarians' health at risk. And we're here today with sort of a brief overview of one of the major contributions that we think that we can make, which is sort of in terms of health systems reform through the proposal that we're actually introducing, which is this notion of integrated ambulatory centers. And it's really a three-stage approach to addressing Ontario's critical surgical and procedural wait times. And with consultation through a number of different avenues, including clinical expertise, including health system leaders, we've recommended a solution that we believe calls for the most significant ambulatory modernization in over 3 decades. And what we're calling for is the creation of publicly funded IACs, or integrated ambulatory centers, that Dan was actually just describing. And the idea obviously is to reduce wait times for surgeries and procedures and to keep pace with healthcare needs in our growing and aging population. And so these integrated ambulatory centers, or IACs, that, as we'll kind of come to talk to them, kind of refer to them as, offer a broad spectrum of surgeries and procedures with a low range of complexity that could actually, we believe, be done safely and efficiently on an outpatient basis. And Jim and I will actually start off the panel by walking through the recently released policy proposal, after which we engage in the panel's discussion and answer some questions from the audience. So we'll move on to the next slide. So what's the case for change? It's pretty clear. Lengthy wait time for surgery and medical procedures were an issue even before COVID. And unfortunately, the pandemic has been an accelerant for these gaps. And I'm reflecting on my day-to-day. This morning, I went to the hospital. I work in a rehab center in the west end of the city of Toronto, and I'm a physiatrist. And so I see both upstream and downstream of surgical and procedures that need to be done. And I saw today a gamut that runs from patients who just came out of surgery who need rehab, patients who are still on a wait list to get a surgery, and then patients who've had either their surgery or their procedure delayed and are now sort of in a chronic state of whether it's pain or functional impairment. And so these are the types of patients that I see on a daily basis. And so this actually matters not only to the patients that we serve, obviously, but it matters to the physicians and the other healthcare providers on the front lines delivering care, and not being able to do that in an effective and efficient way really, I think, dampens our ability to provide effective care and meaningful care. And so obviously the pandemic, given the numbers of shutdowns that we've had to endure, at least here in Ontario, and of course broadly across the sector, across the province, and frankly across the country, we've seen an unfortunate ramping down of non-urgent surgeries and procedures in order to free up hospital capacity. Now, this had to happen because we didn't know what we didn't know, and we had to make room in order to be able to deal with COVID-related patients. And we saw this acceleration of inpatient need through the first several waves of the pandemic. And so as you start ramping down services, obviously in a different environment, you start creating pressure on the existing wait times that now span close to 21 million healthcare services across the province of Ontario. And of course, this doesn't account for the unknown numbers of missing patients who either didn't engage with the healthcare system or were lost to follow-up, or really didn't have access to that front door of healthcare, i.e. primary care or other services, in order to have referrals and a linkage into our system. We also know that we have not only an aging society, but a growing society. So when we think about the immigration strategy in the country, we expect this to grow quite substantially. We also know that healthcare utilization increases as one ages. And this is, once again, the patient population that I see, the geriatric population, require more healthcare services. And so this combination of not only demand, but also growth in that demand is going to challenge our system moving forward. And it's why we believe that we need to be able to face these challenges head on with a new model of care, really focusing on a transformation. And this is not obviously I don't want to say not a novel concept, because it's been done in other jurisdictions, but shifting appropriate day surgeries and procedures to ambulatory centers have actually been successful in reducing wait times in places like Western Europe and like in the United States, like in other jurisdictions. And they've actually been linked with improved patient experience, improved recovery times, shorter lengths of stay, and in fact, lower infection rates. And so this really, at a system level, is actually better for the system in terms of cost efficiency and flow through when we think about getting people the care that they need at the time that they need it. And so Ontario's current ambulatory care model, sort of the IHF model, the independent health facility model that most of us probably in this room know about, was introduced 3 decades ago. And this model hasn't been modernized to meet the changing demands or patient needs that we've come to expect and are faced with on a daily basis here in the province. And the vast majority of IHFs, of course, as we all probably know, are licensed for diagnostic services, with only a small minority licensed to deliver publicly funded surgeries or procedures. And this is despite efficiency and quality gains that, of course, have been realized through shifting such procedures to ambulatory clinics. We have to expect and also understand that, procedural technology and medical advancement and innovation and technology have actually, over the past 3 decades, moved quite a bit. And so we should probably think about evolving our model to not only meet the demand, but also the new technology that exists in this space. And so it's evident that shifting these types of surgeries and procedures, which we'll outline, and Jim will kind of walk us through a little bit of this, will actually ease the pressure on overburdened hospitals. We're seeing this right now. We see this at every flu season time. We see this now with every COVID spike. Being able to take some of that pressure off these acute centers and these emergency care centers is going to be very important to be able to unlock some of the efficiencies and scale up our service delivery. And so with that, I'll hand it over to Jim, who can talk a little bit more about sort of the technical aspects of the IACs themselves.
Thank you, Adam, and thank you, Dan, and welcome to everyone who's listening in tonight. This comes from a recognition that Ontarians don't have access to a service which is present, as Adam said, in virtually every other jurisdiction in Canada, or at least to the same extent. And this is, for reasons that I'll explain, taking off across the world. And this was recognized in the recent Auditor General report, who also recognized that Ontarians were not advantaged. So as Dan said, we had the privilege to work with Santis, and that was important for us because we wanted a little bit of arm's length. So Dan and Isabella were excellent at getting some very candid information that we think was critical to the development of what we hope addresses the majority of issues. So this was extensive member and stakeholder consultation, and the 2 most relevant stakeholders were the Ontario Hospital Association and the CPSO. And of course, we have a large group of specialty groups at the OMA who provided us excellent advice. And I would have to say there was consensus across all of the stakeholders that Ontario needs a more distributed and integrated ambulatory care delivery system for surgeries and procedures. Next slide for me. So we had to start out with some guiding principles, which we thought was important. Anything we came up with had to integrate with the public health care system and the Canada Health Act. Equity and the quadruple aim, which I'm sure you're all familiar with, which is patient experience, population health, efficiency, and provider experience, whether this be in the hospital or the community. And as will no doubt come up in the question and answer period, and I'm sure Melissa will bring it up, there is an acute crisis for HHR. And of course, that's irrespective of where a patient, whether they get their treatment in a hospital or a integrated ambulatory center, we're going to have to come to grips with this. And it's only been compounded, but what we see is healthcare worker burnout. And then finally, it needs to align with the current system needs, whatever that may be. And I'll return to this point subsequently. Next slide. So we're calling them integrated ambulatory centers. And again, as I'll explained, this has to be a staged approach, and it's going to take many years to reach a comprehensive and fundamental change to the way surgery and procedural care. And the key is to create a robust and integrated community-based ambulatory care model. And this idea of partnership and grounded in the community is absolutely critical. So as I've suggested to you and Adam has said, this would emulate the experience worldwide that operationally and physically separating inpatient and outpatient surgery delivers more efficient and higher quality care. So I drew on my experience as a surgeon in chief, 10 years at Sick Kids, about 12 to 13,000 procedures a year, 18 operating rooms. And despite enormous efforts to try and deal with 3 separate streams, the inpatient, the outpatient, the emergency stream, despite everyone's best efforts, we could only achieve what I think might have been a 5% efficiency, whether we know if I could have created it, if I had an ambulatory center, about half our surgery at Sick Kids was outpatient surgery, that achieves 20 to 30%. And these are Canadian figures, Saskatchewan particularly, which was drawn out by the Auditor General. So this is an experience worldwide. I'm not saying hospitals can't improve their efficiency. They clearly can, but I don't think they can ever achieve the same kind of efficiency as when you separate out these ambulatory centers. Next slide. So as you'll no doubt hear, there are a variety of issues, particularly the HHR, which needs to be started right away. And that's going to confront the system for a while. So we're not ready to start these centers right away. So we need to continue to work with the government, which has done a great job of increasing the funding and leveraging the existing capability to deal with both the backlog of surgeries and the previous wait times. And that's occurring through targeted funding for the areas of highest need and the longest wait. But while this first stage is going on, it might be a year or two, it's time to begin to test some of these partnerships between the hospitals, the acute care centers, and these ambulatory centers. And as I've said, at the same time, we need to deal with the HHR issue, because it doesn't matter whether they're ambulatory or they're inpatient, we're going to need the staff to do so. In stage 2, which is probably a couple of years from now, this is going to require some new legislation. The current legislation, which governs independent health facilities, will need to be fit for purpose. And we have some ideas about changing the quality framework for these new ICs. And as some of the IHF licenses begin to expire, we'd like to see beginning of partnerships, formal partnerships between these IACs and the hospitals. And then something which you've no doubt heard about, which is the idea of single intake, particularly for surgeries and procedures. This is being piloted in several areas, but increasingly, this is a model that allows wait time to be harmonized across regions. But I will reinforce this needs to maintain patient choice and existing referral patterns. So we see this as a parallel system to the existing patterns of referral. And then finally, in stage 3, we would like to see new IACs coming online, the IHFs transferring over to a IAC, and then embedding these IACs in the regional health and perhaps Ontario health teams, so we can integrate the care delivery, but also recognizing that surgery, whether it's inpatient or outpatient, requires primary care at the front end and after discharge, but also requires coordination with home care and community care. And of course, that's the vision that Melissa articulated several years ago when she advanced this idea of Ontario Health Team. So this is the final stage, which we could be in a couple of years, but maybe as long as 5 years before we're able to realize this. Next slide. So I'll keep coming back to this. There is a profound HHR shortage, and at the same time, we're addressing shifting to a combined hospital and IAC model. I think I've already commented on it's critical that the IACs would work with the regional plans and hospitals. An IAC may not make sense in every region in the province. but they needed to be publicly funded, OHIP insured, surgeries and procedures. A key thing that we are concerned about, or has been expressed by the IHFs, is this idea of skimming, that low acuity, high remuneration cases are being taken away. And the funding model, and we've got some ideas how that would happen, needs to ensure that there is not this competition for these low acuity, high remuneration cases. And then, as I referred to, strong clinical oversight regimens and partnerships with the public hospitals to ensure quality is across both centers, and the physicians move back and forth across both care delivery models. Next slide. So that's really the end. It's just a very rapid overview, and the white paper that we released has many of, if not most of the details, but no doubt through the question and answer, we'll have an opportunity to discuss more. So over to you, Dan.
Thanks for that, Jim, and Adam for kicking us off. In terms of the discussion, I think I'm going to start with Melissa and ask her to respond both from the perspective of having worked on this issue from a policy perspective for many years, but also now seeing it from the perspective of frontline service delivery. So when you look at the immediate challenge, and then the challenge a few years out from both the organizational perspective and the system level imperatives, can you share your thoughts, Melissa, on what you think needs to be done at the system level to support this kind of distributed, regional, integrated delivery system that Jim was just talking about?
Yeah, I think that's a great question. I mean, to me, there's so much that's in this paper, and the way that Jim just described what is being proposed that is addressing a lot of the key challenges that I think we would normally be talking about when we think about IHFs. Like all those key challenges, Jim, that you just went through are things that come up whenever we talk about the IHFs right now. There's worries about cream skimming, there's worries about, our HHR capacity, et cetera. So I just think the way in which you've actually attempted through the paper to articulate how we could be addressing that, and also talking about the stages. And I like the fact too that you're talking about stages over a long extended period of time. It's 5 or 6 years of development makes a lot of sense. And in fact, the first stage that you speak about in particular, building on the existing processes that we've currently been working through, continuing targeting funding to reduce the backlog, and then creating those partnerships, to me, that all makes a whole lot of sense. What has been a challenge for us in the last many years when we were looking at this many moons ago, 2003, et cetera, is we were looking at it from the perspective of the existing IHF processes and the existing policy associated with the independent health facilities. And I know, John, Kensington is really a different beast in comparison to some of the others, but there never felt like there was a connectedness between the system partners, and it often felt like in fact, it was quite disconnected. So decisions about what an IHF would get in terms of volume, decisions about how exactly it would get funded and operated were completely separate from the whole processes of how we were determining how hospitals were getting funded and how hospitals were getting their access to volume. So I think your question, Dan, when you start talking about what would a hospital say as we move forward? I think so much of what has been built into this plan in particular, it just seems quite logical, to be honest with you. And I can see I can see where you were coming at this from a policy perspective. I still think, I just want to make sure that I say this, I still have some reservations about moving this direction, just because I think there are concerns with the existing IHFs as they are today. And some of them come back to, we say that we can have better, the wait times are going to be better, but Ontario's actually almost always had better wait times and better access than other provinces, and other provinces have access to these, ambulatory care centers. The second is sometimes we talk about it being cheaper, but I don't know if that's necessarily true. It really depends on the hospital that you're talking about. So I think it depends. And then I guess the last thing that I would just say, and you've actually built it into your plan, is talking about central intake and assessment. And I would just say to you, we could get very far if we just moved on central intake and assessment. I wonder, if that, and I'm glad that you have it as part of the strategy, but I think we could actually eliminate a lot of the backlog if we just focused on strategies around that. There's comments from me.
Jim, do you want to address any of that, or do you want me to move on to John and ask him to provide an IHF perspective?
So no doubt they'll come up. Like I admire IHFs. They've done a good job of meeting a low acuity. And as you said, Kensington is a center to be admired and emulated. But there's only about 20 or 25 of these in the entire province. So this is an underutilized resource. And I'm not sure, Melissa, I know all the factors that can determine whether we have good or bad wait times. So all I can tell you is that the comparable procedure done in an integrated ambulatory center achieves efficiencies of 20 to 30%. That's not my figure, that's the Auditor General figure, that's a worldwide figure. If that is true, then the publicly funded healthcare system, if we could take those patients and do them in an ambulatory center, you could do 30% more for the same cost, or you could do the same number of procedures in 30% less time, more efficiently. So that's something Ontarians deserve, and we have to figure out. So I appreciate Melissa's concerns, but we have to figure out how to get there, and that's why we've worked so hard to try and anticipate. The legislation is a key step. We're going to need to relook at that legislation and get fit to purpose legislation that deals with these issues. I'll stop. Thanks, Dan.
And John, I was wondering if you could respond from your time in Kensington. I mean, Kensington did receive significant funding on a case basis from the Ministry of Health because of this, the belief that it could rapidly ramp up volumes for cataract surgeries, that it could do that at a demonstrable cost savings. Kensington has, I guess, struggled to work through how to ensure an integrated system in partnership with the hospitals in the downtown core. Can you talk a little bit about how you see building on what you've done at Kensington to advance an even more integrated delivery system for patients needing care?
Sure. Hi, everyone. Good start. Thanks, Jim. Thanks, Adam and the OMA and Santis for this fantastic paper. I think it's groundbreaking. I think it was timely, and it's a direction that this government should look at seriously in addressing some of the recommendations in the paper. Maybe I'll start by giving some of the features that make Kensington, as Melissa put it, a bit of a different beast. And it is a very different beast in the sense that we have partnerships with hospitals. And I think that is a key underlying feature. So on the Eye Institute, where we do 13,000 procedures, the bulk of them cataracts, routine cataracts, as well as the subspecialties around retina, glaucoma, cornea transplants, and so on. But we are the major center for cataracts for the downtown core for all the hospitals. So the hospitals do not do routine cataracts, they do complex cataracts, emergency cataracts, but we are the center. And we have over 50 surgeons that come from Sunnybrook, Sinai, UHN, St. Mike's, Unity Health, Toronto, St. Mike's, that partner with us to provide those procedures. So it's not taking away from the hospitals, it is their volume that we're doing on behalf of the hospitals, done by hospital surgeons in a non-hospital environment. So that's one key feature. Actually, there's two there, hospitals and hospital surgeons doing the procedures. The third key feature is we are academic. It's very unusual for a non-hospital organization to be fully affiliated with the University of Toronto Faculty of Medicine. We teach. Every single student that goes through the ophthalmology program, a medical learner that goes through the ophthalmology program at U of T is trained at Kensington. Another key feature is that we are purpose-built. So we are not doing GI in the Eye Institute. We are not doing plastics. We're not doing orthopedics. We were purpose-built for ophthalmology. All the processes in the workflow are geared to a very narrow set of procedures. And because we do 13,000 of them, we get really, really good. We recently published a paper that showcased how our costs actually dropped from the initial funding per case because of the efficiencies gained by doing a critical mass of volume. When you do that many procedures and only a narrow amount, type of procedures, you get really good and you get really fast. So efficiencies are gained and cost efficiencies are gained. In terms of process efficiencies, here's one statistic that sticks in my head. Pre-COVID, our turnaround time between procedures was 7 minutes and 43 seconds. In any other hospital, it's well above 15 minutes. And so when you think about it, you say, oh, it's only 8 minutes, but you think about 8 minutes per procedure, we do 80 procedures a day. That's unused capacity in the system that can be taken advantage when it's purpose built. And so we've carried these features over into other surgical specialties like colonoscopies and endoscopies, where during the pandemic, through the government's alternate health facility directive, we have partnered with Unity Health St. Mike's and UHN Toronto General to do hospital cases at Kensington using the same underlying features. I won't talk about pricing. I guess we'll talk about that a little bit later, but I just want to give the audience a bit of the key features of what makes Kensington that unique beast.
Thanks, John. One of the questions from the audience, I think, builds on that point, that is there a concern that there's a tension between specialization and fragmentation in the, or integration in the system, so that a sense that this question said hospitals, especially academic hospitals, have always been siloed. If we go down a route where you have specialized eye centers, specialized orthopedic centers, is there a risk that care becomes more fragmented? John, maybe you can respond to that quickly, and I'd like Adam to jump in, because the OMA in the past has been quite opposed to just the expansion of independent health facilities in a way that's not integrated with the system. So I'd like to delve into why they're supporting this concept, but not the previous expansion of the existing IHF model to a broad range of surgeries. So to you first, John.
I think it's logistics that really support my view of specialization. I think when you do a series of procedures related to one particular subspecialty, as I mentioned, you get really good and efficient. When you start to add different subspecialties on top, the skill set gets fragmented and you start to become a hospital. So when we're operating 6 days a week, which we are now, there's very little capacity to take on additional procedures. So I think my preference based on our Kensington experience is that specialization for certain type of IHFs is the way to go.
Thanks. Adam, do you want to address the concern about system integration and fragmentation with a bunch of different IHFs that do different things? Why is this approach different?
Well, a couple of things actually I think are salient to this conversation. The first being, yes, Kensington, and we're talking about downtown Toronto hospitals. Let's be very clear. That is not the center of the University of Ontario. And in the GTA, which represents the vast majority of people in terms of concentration, that includes places out in the Golden Horseshoe. It includes in northern, communities like Newmarket, Aurora. I talk about York Region, go all the way out east to Scarborough and beyond. We have to figure out a way to deliver care to those folks who can't get downtown, where academic centers are great and for research and development and all of these things, but that's not where the vast majority of people live. And we can't continue to think about silos of care only being delivered in very, very specific, narrow windows of quote unquote expertise, and forgetting about the rest of the communities that actually deserve and need care and frankly have been denied care based on equity and other factors. All to say that we need to be able to expand. We have a numbers crunch right now. We have a supply and demand issue. They don't match up, and we're a growing and aging society. So we need to do something about that. And we're well past a debate about whether or not people should deserve care or whether we should be up higher on that list of 11 countries on the OECD list of the Commonwealth Fund, for example. And so I think right now there's a recognition that we need to scale up our capacity. We need to level up right now and being able to, for example, leverage non-academic but publicly funded hospitals that exist, Scarborough Health Network, North York General Hospital, up in Trillium, et cetera, places where care is going to be important to deliver, but establishing partnerships that are not strictly academic and don't require, for example, physicians to have an academic appointment, which, by the way, is a significant barrier. And you'll find that many new graduates actually don't want to do academic medicine for all of these various reasons. We need to be able to still expand our capacity. So establishing those partnerships is going to be extremely important, and using an IAC model allows for us to have these concepts be sort of woven into an infrastructure that not only can rest on expanding capacity as we're talking about in stage 1. So, making sure we're using all the capacity that there is right now. So extending OR times, funding those, perhaps overnight, et cetera, et cetera, et cetera. And then building these memoranda that then lead into these IAC models of care. And the only other thing I would want to sort of mention at this point is that as we start thinking about scaling, as we start thinking about care delivery, we also have to remember that COVID's going to continue to challenge our HHR, right? Like we at the hospital today, like literally today, we had a bunch of our staff having to obviously isolate because they've had COVID and BA2, et cetera. And so we're still not out of the woods yet. And so we have to not be dogmatic about timelines. We have to understand that we should be probably flexible in how we proceed. And hopefully that that gets to a point where we're able to more predictably manage capacity in the coming months and hopefully years.
Thank you. Jim, I think you wanted to jump in on this too.
Yeah, I want to reconcile John's statement with Adam's statement. I see there are 2 steps to achieve efficiency. One is what I call the operational physical separation. That gains you a certain amount in that people who work in ambulatory centers, they get used to faster turnover and they do things at a faster pace. The patients are healthier, they're more comfortable running the patients through. The second step of achieving efficiency is what John said, which has been called the focus factory. If you can create an IAC that does only one thing, there's another level of efficiency you can gain from that. So I see this as a trade-off. There'll be metropolitan areas where we probably can have an orthopedic IAC, we can have an ophthalmology IAC, we can have a gastroenterology IAC. But if you go further north, I don't think we're going to be able to support all of these specialty IACs, in which case you have to trade off the focus factory for a broader opportunity to integrated ambulatory care. So I think this is going to become a regional question, and as go back to Melissa's point, that's why the planning and the integration with the planning and the acute care institution becomes so critical. And there's some regions that probably can't even support an IAC. Well, fine, then you have to talk about geographic access. So this is why the planning is so critical. So I think you can reconcile John's view, which is big metropolitan areas, but you can also reconcile Adam's view is a little flexibility when you move outside the big centers.
Thanks. We had another question that came in, perhaps unsurprisingly, about health human resources. And I know this was a question when we were discussing this with the panel in preparation for this, is how do you make sure with a single labor pool across the health system that when you're introducing a new organization, the IAC, that's going to be ramping up and delivering care, that we're not poaching staff from already underserviced organizations in the community sector or in the hospital sector. Melissa, I know that this is an area of acute concern for the hospital sector. We do a lot of work with hospitals on strategic planning. Many of them, their number one issue in terms of COVID recovery. Can you talk a little bit about how you would, what you would need to see in place from a health human resources planning at the regional level to make sure you have the right people working in the right places?
Yeah, for sure. And I know others are going to want to comment on this as well. I mean, I think, some of the cautious optimism about this comes from these concerns that hospitals would raise. And it's not just hospitals, it's the physicians that work within hospitals. Whenever we think about creating integrated ambulatory clinics, the questions, it always comes back to, will the quality of care be good? How are they going to staff it? Are they going to end up poaching the staff from the hospitals? On the physician side too, if you steal the skilled workforce, the physicians from hospitals, who's going to provide the on-call coverage, who's going to support the emerge, those questions come up. Who's going to provide the oversight for the organization as well? And then it creates this disconnected care. Like, there's probably other things, but those are kind of the thing. I know that those are the discussion points that end up coming up every time we talk about this. under other situations. And staffing is always the second one. It's quality first, and then it's the concerns about staffing, and it's the staffing from a nursing perspective or other disciplines, as well as the physician staffing in particular. I think, one point that I would just say, and anyone who's here from other hospitals will know exactly what I'm talking about, but during the pandemic, and John, you would have experienced at Kensington too, because that's part of my point, but the pandemic has really taught us that we are losing. That great resignation is happening right now. We are losing staff and skilled workforce. And Jim, you were talking about that specifically as well, that you're really worried about the mental wellness for our staff as well as physicians. We're losing this workforce. And what is an absolute concern with this is if we start to move and shift this out of the organizations, how exactly are we going to make sure that we can continue to do the work inside? And so I think we would have to understand how exactly we can protect the workforce that's working in the hospital sector from really being depleted out from the hospital sector into these ambulatory clinics. And there are ways to do that, Dan. I don't know if you wanted to talk about that specifically, but we know other jurisdictions have done that, where the poaching of staff is something that through that regulatory process, you can put in regulatory requirements. In fact, it's even in the paper that's one of the recommendations. So I do think you've covered it, but that would be essential for hospitals to want to partner. I also think, though, that hospitals would be willing to actually share the staff in some way or another, although you lose the efficiency, because we would have to address how you're paying for those staff. So, I mean, all the labor relations associated with that would have to be considered, but there might be the ability to actually partner on the staffing front too and be able to utilize staff between. And then I guess the only, last just important point that I would just raise is that one of the benefits that we have had, and I appreciate that we've had to defer care, absolutely. We've been able to prioritize, though, the waits for cancer surgery. There's great examples, I think, where we've been excellent during the pandemic. But, one of the features of so much of this happening in one institution is that we've been able to do the level loading. We've been able to actually take staff from here and there and actually support the full pandemic response. The more we separate it out and we silo things, especially if these ambulatory clinics are not large enough, the harder it would actually be to respond to healthcare worker crises. And I guess another point that I would just say is, that healthcare worker crisis is not just in hospitals, it's across the entire sector. And in fact, it's every sector. We had to have a command center table meeting, urgently on Thursday because our Tim Hortons was going to have to close. Like, this is not just a healthcare problem. This is an everyone problem, and it's not just a hospital problem. It's an everywhere problem. So it would be a problem for these ambulatory clinics too.
Thanks. John, do you want to speak to that from an operational perspective of how you've managed to not compete with the hospitals that you work with for both physician and other clinical staff?
Yeah, I think the great resignation has happened at Kensington too. You know where they're going? They're going to hospitals. So on one hand, your hospital leadership are saying we're going to lose staff to IHFs. Well, I think every single IHF would agree with me. Everyone's going to hospitals. So no one wins here, as you quite well pointed out, Melissa. So I think we had one beauty of the pandemic, not much, but one of the things that I don't know still exists, I think it still does, is the Public Sector Labor Relations Act was suspended during the pandemic with emergency orders, which allows unionized and non-unionized environments to commingle, which were essential for long-term care. At Kensington, we also have long-term care, and we benefited by our hospital partnerships. So if that can be achieved through whatever regulation to allow staff to move between, I think that would really help resolve our HHR crisis. The physician part, and this is how I pitched the leadership at the hospitals, which you're quite right, Melissa, I'll share your view. And what I said to them was, this is a hospital program. It's hospital dollars, it's hospital patients, and it's hospital physicians. We provide the facilities and the nursing support, and we take all the risk as well. So when it's pitched like that, it's not shifting. We're not shifting anything. Hospital OR staff are still busy. They will always be busy. It's more of a reallocation of where the actual procedure is done, not hospital losing volume. It's just a different care setting. right place, right time, right, that kind of phenomena is what this partnership is about. So we are not stealing surgeons from the hospital. Your point on quality, I think there's a big myth, and I can't speak for all IHFs. I would say that the quality is unknown across IHFs. There's great IHFs and there are not so great IHFs. And I think we can also say there are great hospitals and there are not so great hospitals. But the big difference is that there are no quality metrics evenly applied across all IHFs, with the exception of CPSO inspections, which are quite rigorous. In many ways, I find that the inspections are even more tough than hospital accreditation processes and so on. But in terms of quality metrics around outcomes based on the type of procedures, I would agree it's uneven. And I think that's one element that indicated in the paper is to create the standard. What is the clinical standard? So if it's ophthalmology, let's be clear on taking the clinical handbook from the QBP, although the QBP clinical handbook does not apply to IHFs, but it's very similar to what we do out of the hospital, but apply it evenly across all care settings. So whether you do the surgery in the hospital or in a community environment, it's the same across the board. So creating that quality regimen provincially.
Jim, did you want to jump in on the HHR question as well?
John made the point, which is the procedure or surgery has to occur somewhere. So it either occurs in an ambulatory center or it occurs in the hospital. So the idea is staff are needed wherever the patient needs to have their procedure. So this is a system level problem, and I'm afraid I don't have a solution for the nursing crises and the Tim Hortons crises. Those are real economic consequences that we need to deal with collectively, irrespective of where the procedure is done. But I just want to, John focused on the CPSO. We have quite an unusual situation here where the licensing body is also serving as an accreditation body or an inspection body. And that seems like a peculiar situation, which I think I'm fair to say the CPO is not entirely comfortable with. I mean, they do a good job, but they're a licensing body. And we envision a quality improvement plan, which is negotiated between the acute care institution and the ambulatory centers. And there's an Accreditation Canada. There is a separate ambulatory accreditation accreditor. So maybe they work in concert and they come in and they look at the combined service delivery with the metrics that John has said. Finally, the physicians we would see as credentialed both with a very well-oiled credentialing process, which occurs in the hospitals. And then the doctor moves back and forth wherever the patient needs their procedure. This is not a resource which is available to a small group of physicians, which then, as Melissa said, you're competing. And we deal with issues of call, and I would say, John, teaching and research in academic centers, these all would be negotiable, and we take great optimism from Kensington that this can be done. And the last piece on the labor, that is an issue. Melissa, I don't have an answer for that because unionized and non-unionized is something we would have to sort out, but that could be managed through the legislation. So I'll stop because I know Adam has a comment.
Adam, over to you.
Yeah, thanks, Dan. And certainly building on what others have said, we have a phenomenon in this country and in this province where you have a wait list for specialist care and underemployed specialists, right? Orthopedic surgeons can't get jobs because there's not enough OR time, or neurosurgeons who have to do 3 fellowships before they can subspecialize in one very small area that an academic institution might have capacity for. And so we have a labor and supply mismatch here that can actually be used and leveraged in the right way. So call new surgeons, new orthopods who want to come in and do hips and knees from 10 p.m. to 10 a.m. You'll have a line out the door, getting those folks, at least early career physicians, to operate. So we have to, I think, be flexible with our understanding of HHR and have hospitals bring in that capacity and say, you know what, okay, we're going to try and leverage this for the greater good, especially at a time when care needs to get done. That's the first comment I have. And the second comment about nursing and other, this is where immigration is going to have a role to play. And this is where political leadership, along with our health human resource strategy, has to dovetail with an immigration strategy that can actually bring labor from elsewhere. And there was already a huge push for some of that easing of restrictions, easing of bureaucratic credentialing that can actually scale up the needs that we have. And so this has to be part of the conversation. I don't think we're doing that enough justice, I think, in this country. And I think it's time that we start paying our attention a little bit towards an immigration strategy that requires some federal, provincial, and then hopefully some regional coordination.
Thanks. I don't know who said it earlier, but they said at some point we'll get to all of those gnarly questions around funding. And one of the questions from one of the attendees asked, what do we have to do in this model to ensure that the funding would be sustainable? The other side of the question is, what do we need to do from a funding perspective to ensure that hospital finances aren't made unsustainable? So we know that the history of ambulatory clinics in the UK caused some problems with hospital finances as the more routine cases shifted to ambulatory centers. Jim, do you want to take that one on, given your economics hat at the OMA? It's obviously not an easy answer to this, but how do you ensure fair funding for these new ambulatory clinics in a way that doesn't disrupt system stability?
So the first is to recognize that skimming is a key factor that puts hospitals and ambulatory centers in competition. So this is absolutely fundamental to hospitals and IACs working in partnership. The idea that it's great for care, but the hospitals can't be left with the high acuity, low remuneration cases. So that's the first thing. How would this be achieved? We envision 3 possible routes. One, that there could be a separate funding model based on acuity, which accurately represents the cost. So if you have a high acuity, so first of all, it's both patient and procedure. So there are some patients, even though they're having a low risk procedure like a cataract, have to belong in hospital. And there are low risk patients, or high risk patients low risk patients who have a high intensity procedure that also belong in hospitals, okay? So this is for low acuity patients, low complexity procedures. So there could be a funding model which the government could set, not an easy task, but everyone agrees hospitals are not losing if these cases shift. So that's one option. Second option is you give the money to the hospitals and the hospitals contract with the IAC saying, we'll give you so many cases at such a pay rate. That way they're in control of deciding what they're willing to give up and what they're willing to pay. The third, and this gets to the clinical commissioning group, which was my experience when I lived in Oxford for a couple of years, is the clinical commissioning group actually contracts out. You could imagine, potentially, in a mature state that the OHT with some kind of regional buying authority says, okay, we have so many cataracts, 10% goes to the acute care hospital, 90% goes to the ambulatory. We have 100 total hip replacements, 90 go to the hospitals and 10 go to an IAC. So we have 3 different options. I'm not sure what the right one is, but we'd like to work with the ministry to figure out which of those is most feasible, and it would be done with the OHA to make sure that everyone agreed this is a fair way, because we have to get over this problem of skimming.
John, you talked about the faster turnaround times at Kensington. You've talked about the efficiency at Kensington. I know when I was in the Ministry of Health, one of the things I found deeply frustrating is I never understood the truly comprehensive cost of a case of even a cataract at Kensington versus in a hospital. And if we couldn't understand that, it seemed to be quite difficult to figure out what are the types of procedures that we should really be looking at as cheaper in an ambulatory center like Kensington versus in a hospital. Intuitively, it seemed to make a lot of sense. I saw the facility, I saw what you guys did, the volumes you could churn out. But can you talk a little bit about, I guess, the difficulty and transparency in understanding the true cost of care, and then how to fund appropriately for services done in ambulatory centers versus hospitals?
Yeah, so thanks, Jim. I think those are 3 reasonable options. And just for the audience, just to give a bit of a backgrounder, there is a myth that IHFs get more money for the same type of procedure, a cataract, than a hospital. It's true. We do. In fact, we get about, on average, depending on the hospital, but on average, let's call it $200 more than what a hospital gets per cataract. And the reason being is, in that $200 includes a facility fee, which helps pay for the equipment, the overhead, and so on. Hospitals have something similar, and they can fund their cost, their lower cost, with their global budget. So their overhead is covered there. When we work with some of the downtown hospitals around negotiating a price point, we took 2 years and we could never agree on a cost per case because we had very different ideas of what our costs were, and no one could really explain their true cost. We can because of the way that we're funded. And so we ended up disagreeing for 2 years. And finally, and so one other option, Jim, is what we have done during the pandemic for colonoscopies is we've taken the hospital price point. But we've taken the hospital price point by not taking all of our volume from the hospital. We will continue to get our normal volume at our IHF price point, and any incremental cases that can be done, we will take at the hospital lower price point because the cost efficiencies have been gained by doing the critical volume. But if you're telling me, oh, here's 200 cases, go try and make a go of it. No, thank you. So it's a blend of, here's your funded IHF volume, maybe accounts for 80% of your capacity. Here's 20% more that you can fit in, but it's going to be at a lower price point. And then you have a choice. You can do the contracting model, like you said, whether it's through the OHT or hospital direct. And I think in that blended way, because we tend to blend things here, because we can't get rid of anything that we've created in Ontario, we have to blend things. And I think that might be a preferred path where the organization doesn't lose their shirt. And I should highlight that Kensington is a not-for-profit charity. Our mandate is to be cost neutral, maybe a little bit more to help pay for that overhead. And even then, we struggle to generate that margin based on flat cost per procedure and increasing costs and expenses for everybody. So I think there is a creative financing solution that doesn't put anyone, patients, surgeons, so no out of pocket for patients. Surgeons need to make a livelihood. Hospitals aren't dinged on their funding model because IHFs skim the easy cases, and the IHF themselves need to pay for their overhead.
Melissa or Adam, anything to add to this?
Yeah, just a comment that I was going to make is that this is, again, one of the areas where I think you've really addressed it in the paper, and Jim talked about this specifically too. And I think what John was talking about there is really important. You know, a point though that I would say is that there's very few, unfortunately in Ontario, there's very few areas where we're actually good at figuring out what the costs are of things. But this is an area where, from a hospital perspective anyway, we actually have good data and information about what the cost structures are. And we also have processes that we could be capitalizing on more than we do today. We did a great job of it in 2003 and probably for 10 years. And then we've gotten, and I'm just complaining because I think the QBP funding needs to be adjusted. I mean, we've kept the same funding rates for years and years. Like, these things need to be adjusted, but we do have the mechanism. We have a hospital advisory committee. It could be, you know, the OMA could participate in that. I think there are ways in which we could figure out a funding model here for sure. What frustrates me is that the IHF funding model is completely independent from the one that's used in hospital, and it doesn't make sense. It should be an integrated model, which is, of course, Jim and Dan, what ended up in this, and Adam, this is what's in the paper. So to me, that's hard to argue with, because it really should be an integrated approach to thinking about that funding, which is exactly what you're recommending here.
I'm gonna turn things around a little bit. There have been a few comments in the Q&A saying, why is it important that we're talking about an integrated model? For episodic care, isn't it okay if these are done just in the most efficient environment possible, whether that's a standalone IHF or elsewhere? Why is this question of connectivity to the hospital sector and integration important? Adam, do you want to speak to that? And then maybe Melissa can comment as well.
Yeah, I mean, I would say that there's a couple of philosophies. On the one hand, you don't want to have perfection be the enemy of the good. So, I mean, if you want to wait for an integrated system, so EMR is a great example. Everyone says, let's have a unified EMR. That's not going to happen. That train has left the station a long time ago. So now let's integrate so that I can get Jim's notes when after, he's operated, or, a family doctor can get my notes from my rehab center, et cetera, et cetera. But integration in sort of care delivery is very helpful, because it helps not only ensure that the proper care is delivered in a timely way across different service providers, across different perhaps networks of institutions, and perhaps even regionally or geographically. That's going to be very important, especially if you start thinking about a centralized referral list where you might have someone from Kenora coming down to Windsor to get a surgery or what have you, and go back if it's the next person up kind of situation. But there's also a balance and a trade-off that Jim would describe, which is that, yeah, we know at some point we need to deliver care in a timely way. People can't keep on waiting. It's not humane. It's not right. And if we have capacity to deliver care, well, we should do our darndest to be able to deliver it. So, and this is where territorialism comes into play a little bit. And so I think that that's part of that political landscape at an institutional level, at a hospital level, at an elected leader level. And so let's not kid ourselves. The politics about this is real, and so we need to try and understand that landscape and work within it, but hopefully expand our capacity to affect change without letting perfection be the enemy of the good.
Melissa, you've spoken to some of the concerns that you as a hospital leader and others in the sector would have around the expansion of standalone IHFs that are able to pull their own patients and staff as they, with less consideration for the regional system. What are your, I guess to summarize, what are your concerns if the government were to move with an approach that just directed volume to whoever could do it?
Honestly, I just go back to some of the points that were made before, who builds the center, what standards are they following, who staffs it, who performs what procedure, who are the patients? It's the same kinds of questions that I think every time we talk about this is the barrier that we run into, which is, and this is actually happening right now. Like, we're a large bariatric provider. There was 3 IHFs. There's now 10 that are providing it. And what do we hear from the physicians and the surgeons? We hear back, we're really concerned about the cream skimming. Like, it comes back to these concepts that we're talking about. And some of these things are real, some of them are not. But this is where, if we worked at it from an integrated perspective, I think we would go farther than us just, than the government coming out and saying, hey, go ahead and do whatever you want. I actually think that we would get better quality care for these patients. So I just think that it would be better from an access perspective to do it the way that you've just described in this paper, to be honest with you. But I appreciate, maybe there are some things that, sure, it would be fine for them to be done in isolation, but right now that's not how it's done. And the truth is, it is actually competition, because they are actually being done in both. So are we not better off to try to figure out, okay, who takes what role here? And we could actually work on that together versus it being both of us in silos having, siloed conversations about this. I just think, given everything else from in an Ontario perspective and our focus on, we want to be more integrated, I can see the value in the way that this has just been described from the team here. I guess, can I just, one point that I did want to say that isn't really addressed in any of the paper anywhere is the fact that some hospitals have ambulatory centers. Like, we have an ambulatory center. It has 4 ORs. It's standalone. It sits over in Stony Creek. Like, where do they fit into this model? Because we sort of forget, or we talk about how, the hospital system is so inefficient, but it's doing exactly the same thing that Kensington is doing from the perspective that those physicians that are working there, we do plastics, we do cataracts, and they are fast and very efficient. Where do they fit in the model? My own question I wanted to put out there.
Jim, do you want to respond to that point?
Yeah, another model, Melissa. It's just that may not be possible for everyone. And it gets around the labor issues, but people have said that if you're spreading, there's something about people who work in ambulatory centers. I'm not talking about the physicians, not that I should disparage the physicians, but there is something about the staff who like the rapid turnover and the go, go, go. And there are others who are like, more used to dealing with complex patients with lots of difficulties. So We may not be able to fully realize all the advantages of something which is operationally separate, but of course that's one option and it is being pursued, and we would support that as well.
Something that hasn't come up as a question here, which I'm quite surprised about, is the thorny issue of nonprofit versus for-profit care delivery. So in the past, government efforts to expand ambulatory service delivery have been caught up in this kind of third rail discussion about privatization of healthcare services. Jim, maybe you can speak to this and how the OMA has been thinking about whether these IACs need to be not-for-profit, or whether there's room in the system for-profit, and what the kind of considerations would be around that.
So other than the HHR, the second biggest issue, which has precluded the expansion of ambulatory centers, is this idea that inevitably they are private healthcare. And it conflates somewhat the confusion between publicly funded and for-profit and publicly funded not-for-profit. And in some ways, this is a bit of it's almost a philosophical or political debate. Some people believe that if you have a for-profit model, possibly in gain sharing with the government, that will achieve additional efficiencies that you can't achieve in a publicly funded not-for-profit. I don't know that I don't have the answer to that question, and there are some experiences. I know John's got experience of whether they were able to generate a huge amount of profit and what went to that profit. But if this is going to preclude the expansion, that becomes a political decision. And every time we talk about expansion of ambulatory centers, someone says, oh, that's for profit. So we've talked about the partnership, we've talked about the skimming, those are key components, but this is as much a political discussion as an operational one. So I'm going to stop.
Anyone else want to jump in on that hand grenade of a question?
Yeah, Dan, I can just chime in. I agree with what Jim said. You know, even at a clinic level in our healthcare system. So you have a family doctor or a specialist clinic out in the community. They need to keep the lights on. They need to pay staff. They need to buy supplies. They need to take care of their EMR, and no margin, no mission, right? If they are not taking home any money at the end of the day after all this, and includes the service provider, includes paying your staff, includes what the physician remuneration rate would be. If they're running a loss, they're not going to be in operation. And then 75% of your care across the province goes along with it, right? So 75% of care that's delivered every single day in this province of ours is outside the four walls of a hospital. So we need to stop being so delicate about talking, like I think, in my opinion, we need to stop having that third rail conversation, because it's really impacting our ability to deliver care ultimately to our patients. And that's a problem. And it's grown to be a problem where inaction has now led to lives lost, morbidity increases, disability growth, all of these types of things. So I think that as a society, we need to have a mature conversation, and we can do that if we put our minds to it and have the political wherewithal to move the ball down the field.
Dan, I think the only comment that I would just make on this is that, and you articulate it well in the paper that, and I think Jim was trying to say this too, or articulate the point that publicly paid for, as in OHIP funded, versus publicly delivered services or privately delivered services are two totally different things. And I think there's actually more controversy, maybe I'm wrong about this, about the publicly paid for part of this. If this becomes one of those systems where, hey, you can get faster access by paying out of pocket to get into the system, I personally would have an issue with that. Many Canadians would have issues with that. I think that is, and I think, your first principle, we're going to comply with the principles and guidelines of the Canada Health Act, is exactly right, personally. Others may not agree with me, but I want to just state that. I think whether or not it's publicly or privately delivered, we have all kinds of private delivered services that exist in the Ontario context today. It's less it's actually less controversial. I know it comes up, but it is in fact less controversial because it's being done all the time. It's being done in home care. We know that it's long-term care, etc. And, you know, that's where there is definitely political context as to whether or not it's better or not. But there is a distinction between those two things about the payment system. Do I have to pay out of pocket for that service? That's a whole other ballgame than is it publicly or privately delivered?
Yeah, I 100% agree. It does get conflated sometimes in the public discourse. A lot of the people we interviewed, though, said, you know, essentially that the access to care issue is so fundamental to public satisfaction in the healthcare system that if we don't figure out a way to fix this and ensure that people get access in a timely manner, you're inevitably going to have a conversation saying people should be able to pay out of pocket. There should be private pay because the public system, the public insurance system isn't delivering. So I think what this paper tried to do was outline an approach to say, if we want to maintain the sacred principles of the Canada Health Act and the universal single payer system, we need to change the system to get better access to pay through using innovative models that can really meet that public need in a much more efficient and productive manner. So I think that's what the paper tried to express. It does get confused sometimes, though, when you talk about it. I've certainly seen healthcare stakeholders conflate any private delivery with privatization of the healthcare system, notwithstanding the fact that many of those folks that you partner with in Hamilton or everywhere are structured as private entities providing healthcare, whether it's primary care or whatever. We just have a couple of minutes left. Is there anything that we haven't brought up in this conversation?
I was just going to make a point on that, actually, that last bit of our conversation. Let's not kid ourselves. If you are well connected in this country, if you're a politician or an athlete or someone with a lot of money or a deep Rolodex, you can get care faster than someone who is on the lower end of our socioeconomic ladder. It's a fact, right? You can pick up a call. John could pick up the phone and call 50 ophthalmologists if he had an eye surgery or ocular issue, and I could call one of our colleagues because I know a lot of physicians in the sector. So we do have an inequity in access, not based on our ability to pay, but our Rolodex and our networks. That happens every single day in this province. So let's not kid ourselves that we have an equal footing in access to care. It's just simply not true. And so that becomes our challenge. We sometimes hide behind, well, let's not have access to care based on payment, but we're okay with if it's tiered based on network. And so I think that's something that we have to reconcile, which then brings me to my second point, which is I think there is an understanding and an appreciation that we need to modernize the Canada Health Act. It was written a very, very long time ago. It is now, it's just in the same way we're talking about how hospitals and IECs and IHFs written 30 years ago are not applicable to our current context. I would argue that the Canada Health Act has similar challenges.
Any parting comments from our other panelists?
I'll just add on this last bit as well. I think the clarification of who pays and private not-for-profit, and having been in the long-term care sector for the last 6 years and about to enter home care, where, as Melissa indicated, there is that private and not-for-profit dynamic. But my position has always been it's a sector. So if it's an IHF, it's a sector. There is not-for-profit and there's a lot of for-profit. But if the rules are created the same, then, you know, good on you if you can generate margin. And I'll tell you, and I told the panel when we met for the pre-meet, it's very difficult to generate a profit within the OHIP funded regimen. Now, if you apply the quality standards that we talked about before, and if we go to stage 3 and we talk about concepts of risk and gain sharing as a system where everyone benefits, if you generate a profit gets shared, everyone wins, patients get access, I'm all for that. And so then it's not your letter's patent of what type of corporation you are that distinguishes whether you get access or not. It's if we act as a system, there is room for private for-profit providers who can play in the same sandbox as long as they don't take shortcuts or gamify their ability to generate margin. If we all do it together, then there's enough for to serve the entire community.
Thanks. Feel like we could have had an interesting hour-long conversation just on that topic. But it's been a really interesting, wide-ranging conversation. I'm going to hand it over to Adam for closing thoughts and takeaways.
Yeah, thanks, Dan, and thanks, panelists. I think having a conversation about healthcare in this country it's great fun, and invariably it leads down many paths, and I think it's almost like a Canadian tradition. It's like a sport, so it's like hockey, lacrosse, and then like Canadian healthcare. It's like top three. So and to our participants, thanks so much for joining. I know that. We're going into an election here in Ontario in 8 weeks after 2.5 years of COVID, where it's going to be COVID's going to be on the ballot, healthcare is going to be on the ballot, economic recovery is going to be on the ballot, and so when we think about what the future of healthcare looks like in this province and what a transformation and a required transformation looks like in this province, I think there's an opportunity to really use innovative ideas, new care delivery models, whether it's this one or another one, or being able to drill down on what is essential for the future and for a growing and an aging population. It really behooves us to start doing some of that legwork now, building that foundation for the future. And I think Santis and others do a great job of bringing this to a conversational level where it's on it's on the radar now. And so hopefully this can start becoming more and more central to sort of the policy development and the political discussion that's required, and frankly the political courage to make change happen. And so with that, I want to thank all of my panelists, John, Jim, Melissa. It's great to be with you, and I know that we're going to have many more of these conversations, and we're looking forward to continuing to educate and help learn ourselves about the future of healthcare here. So thanks so much. Have a good lunch and dinner.
Yeah.
I haven't had lunch yet. Literally, lunch is my dinner. So thanks, guys.
Thanks, everyone.